I guess we are live, Samshul.
I'll just tell you, sir. Just give me a moment, sir.
नमस्कार, कृपया ध्यान दीजिए आखिरी अंतिम सूचना उन सभी यात्रियों को दी जाती है जो इंडिगो की उड़ान संख्या 6E508 से दिल्ली तक की यात्रा कर रहे हैं। आप सभी से निवेदन है कि तुरंत क्रमांक 1 से विमान की ओर प्रस्थान करें। धन्यवाद।
Yes, sir. We are live, sir. You can go ahead, sir. Shantanu, sir, we are live. Over to you, sir. Sir, we are live. It's not responding. Sir, my voice is audible?
Yeah, it's breaking a bit.
Yes.
To me, it is breaking. I don't know about others.
It's audible, but it's breaking, Shamsu.
Yeah.
Yeah. Actually, we are live on YouTube and.
Okay. I think there's some problem with this. Or what you can do is, if you allow me to, that is the best way of doing it. If we.
Shantanu sir has some issues, I guess.
Just a moment.
Yeah.
Okay. Welcome everybody. I think welcome all of you all to the IOA Mini IOACON Pre-Conference IFAS CME webinar. Wonderful range of topics. Most of them are on trauma, and there's only one. This is going to be an interesting start. Dr. Rajiv Vora is going to start this session. He's going to speak on ankle fractures. So without further ado, I would and share it on the screen.
Okay. Is it okay? Can you see?
Yeah.
I would like to thank the organizers as well as Dr. Mahindra for inviting me to this in Jaipur, but unfortunately due to some fractures and how I approach it. A lot of functional impairment, and this is particularly, and they are not as easy as we think. So what is my approach? How I approach this is to see whether which malleolus, because this is what you have to undo when you are stable, syndesmosis is involved or not, and what is the quality I'm going to fix it, the devices, the implants I need according to the qualities the patients have, and then the soft tissue conditions. Are they ripe for surgery? So this is a very important slide. I think whenever an ankle fracture is seen in mind, so with this background, we proceed further, stable or unstable. I think all of us agree that these the stability of these fractures. But when it comes to or not, but if you closely see these, if posterior malleolus fracture, you have fibular fracture, so it is quite obvious that this fracture is an unstable fracture. There are different things you can use, the stress test, and then the intra-op stress, you can see the opening of the, once you have fixed, the opening is gone. So these are stability in these fractures. Now, why the fractures become that even when the fibula is fractured and you have an injury to then the ankle or the talus remains within the ankle mortise. It is just when a medial injury is added to it, the talus follows the lateral displacement. So it is the medial injury which dramatically changes the stability. And now we are realizing that the deltoid ligament repair is becoming more, which recommend the primary repair of deltoid. Different papers where the protocols are evolving according to the deltoid. And actually, the deltoid ligament had gone, preventing the reduction even after doing the dual fibular plating. So instead of going into and doing a fixation, we transatmosic fixation. We went on to do to see the instability is the medial clear space, and which is different papers which say even 7 mm is okay. This paper, they took 7 mm, and amended when they were found unstable at different weight bearing X-rays. Weight bearing has been used. So now the weight bearing can also be used. Practice do on repeatedly weight bearing, then we can. The surgery has much better results. The conservative has much better. Okay. Now, after this instability, we go on for syndesmosis injury. The patient, it is one to be bad. And it is now, even if you see the class this into consideration, whether it is involving the incisor. This was the approach. You fix the malleolus and then you do a trial. I have fixed the Chapu fragment. I have fixed the posterior malleolus to keep everything, because there are injury at every level, all round weeks, because everything is stabilized in this fracture. And to repairs, it is not only bone and ligament repair. People are even doing to bone and ligament repair so that you can get the syndesmosis in the fractures. Your PTIFL is attached to the posterior malleolus, and when you put the posterior malleolus back, you automatically have realized the configurations of the posterior malleolus and the posterior malleolus. Now we have a very good understanding of the posterior malleolus posterolateral approach, and this is our posterolateral. Then the incision is made over the fascia of the peroneus, but here I have made incision over the FHL. Now the incision which is made over the peroneus, and now I will just try to develop the interval between the peroneus and the FHL, and you see the fracture has been exposed. This is the fibula which has been fixed, and then this is the posterior malleolus, which is, you can see here, we are getting the compression here once we are putting the buttress plate, and through this approach you can do the posterior malleolus, and this is the same case we could achieve the reduction. Now, if we look, the fracture is predominantly medial and the posterior medial. So in this case, we chose the medial approach. This is the approach I use. So the tibialis posterior, the FDL, and here I have retracted the tibialis posterior as well as FDL, and then this is the malleolus which I am fixing. In case you see, to the posterior medial approach, we fix the posterior malleolus. The concepts in posterior malleolus are evolving initially, as well as the shape which matters. And if you see, initially in ankle fractures, and this is, again, you see now we understand the configuration, two plates to fix the medial component and the lateral component in this fracture. So realization of posterior malleolus is very important. These malleolar fractures, the congruency is improved, the tibio-talar, you get both the ankle and the syndesmotic stability. And you see in this case, we fixed the medial malleolus, we fixed the not stable. So we had still added a transsyndesmotic. Assess the syndesmotic instability by fluoroscopy, stabilized by screws, tight rope, ligaments, and we can achieve the reduction indirectly by dollar fixation and deltoid repair. And you have seen, I've shown you the cases, then we need to check them intraoperatively. There are various radiological, and you need to assess the reduction in these cases, and of assessing the reduction intraoperatively, that once you define the relationship, you get your sense. And both the type of the fixations have their own. By fixing the malleoli, the posterior malleolus or the Chapu. Now I come to the fractures. When you look at the, sometimes you can also have a separate anterior, the two types of fixation has been used. So if it is a conservative, you must keep in mind that malreduced that your medial malleolus doesn't get displaced during the conservative treatment. There are different fixation strategies. You can use screws, you can use TBW, you can use the pulse screws, particularly in osteoporotic injuries, and then plate and screws depending upon the fracture configuration. Normally, the transverse, compression and the comparison, a study where comparison of medial malleolar fractures were done. And when you can use, simple lag screw fixation, particularly in osteoporotic bones, and you can get a bicortical full threaded lag screws in these. So one thing I want to remove it, and particularly in supination adduction injuries, patient which was referred to us, which was fixed like this, and then we had to put the medial malleolus in place. Now I go to the lateral malleolus. Thing again is that whether it is stable or unstable, which we have discussed, the fixation can be done according to the location and the size of the patient. Then for oblique fractures, you can use, if the fragment is very small and one plate is that the posterior plate doesn't cause much of a peroneal tendon irritation, which advocates the posterior plating. And been shown that good results can be seen in open fractures if you do a primary fixation. And to support this wound, you may add a fixator initially so that it doesn't open. And you see, this is the primary fixation. We have done an ankle fracture. This is another open ankle fracture. We went ahead and did a primary fixation. But primary fixation is not possible every time. In cases like this, you may have to resort to the primary arthrodesis, and now this was a compound injury.